So my name's Sarah. I'm one of the physios working at a charity over in kind of West London. I'm going to talk to you today about assessment and screening for virtual exercise groups from a charity's perspective. So that differs a little bit to the NHS because we have a little bit less red tape, but we also have a significant less support and kind of policies. So it's been a very small team, but have made really good strides. So it's been an exciting time. So what did we do pre-COVID? So we're a small charity providing neurological rehabilitation, social support and education for those living with a neuro condition. And we were running exercise groups and education and kind of peer support discussion sessions over in a private studio. There would be about a 20 to 30 minute education session and then 60 minutes of doing a group exercise circuit, which had 12 stations of 2 minutes each for balance and kind of strength exercises, and then we had a little break, and then we did a cardiovascular and agility section where we did 5 stations of 2 minutes, and we had a cool down. So it was very successful and really nice, bridging the gap from people who weren't quite ready to go on to kind of gyms and exercise on prescription schemes, because the groups are run by physios. They get that extra little bit of support after their NHS care has stopped. The model we used to use was obviously people would have a one-to-one physio assessment. They'd come in for the group and they'd do a 12-week block, and then we'd do a reassessment to relook at some outcome measures. And we were just running sessions on a Monday and Tuesday, and kind of in the afternoon we picked a time that was kind of going to be suitable for people who were going to return to work and some vocational kind of aspects of younger people having ongoing rehab. And we had 10 participants in the class, and the cost was very minimal. So it was £60 for 12 kind of sessions, which is great value for an hour and a half kind of input. So we had this lovely space of a studio and great mirrors and equipment, and then suddenly we had to retrain. So as a small charity, we were thinking, well, what are we going to do within COVID? We wanted to keep the group together. The participants get so much out of each other in terms of peer support. It had become a kind of little family unit for them all. And we were very adamant that we wanted the charity to continue and to be able to reach more people, and to try and help during the COVID crisis where we knew the NHS was going to be super stretched. So we were quite innovative as a charity. We had loads of questions, which I'm sure all of you have had during this time, but we worked really hard on trying to act pretty quickly, and we were able to be quite responsive. So the biggest things, I suppose, when we're thinking about what Liana's asked me to focus on today is about assessment. We were thinking about how we were going to assess remotely. As physios, we often like to be able to put our hands onto people and to assess tone and have a little more appreciation of muscle power, and really to look at those kind of functional skills that we have as physios. I think I was quite confident that we were going to be able to do good remote assessments, and that's proved the case. I think movement screening and looking at people's impairments and pulling out how people move in the functional setting of their own environment has been a massive positive for us. We wanted to make sure that participants were coming into the meeting and be able to not be muted. So we didn't want to have a strict criteria on the IT. We wanted to be able to feel like they're having a little social chat to each other, and to gain like a nice social environment from the kind of education and participation. We were really conscious that we didn't want to increase carer strain and burden, because we were feeling like loads of things were saying, well, can the carers help with standing with them, and can you provide extra support when you're in hospital? And yes, we were very aware of keeping people safe, but we did a lot of work on emergency policies and setting up resources for people to think about how they were going to set up their own environment. And Victoria, our head of admin, was amazing, and she kind of supported me as a physio to support people getting onto the platform. We chose to go with Zoom because actually it was really user friendly. It was easy to support people with aphasia and kind of cognitive abilities, and people were using that as their social platform. So we actually thought, though it's had a little bit of chat about the encryption and the safety of it, it's been significantly improved and enhanced, and all of our participants have been really happy, and they now utilize it sometimes with their social aspect, and they speak to each other through it as a medium. So that's a really good skill that they've got out of it. We were very keen to keep collecting outcome measures, and a big part of our kind of focus was to think about how we could get some rich data to be able to look at the success and the kind of challenges of remote rehab, and to look at being able to write that up as a kind of paper and experience, really. So what are we doing now with COVID-19 adjustments? So we set up lots of kind of policies and protocols, as all can imagine, from SOPs, and I do half my job in the NHS still, so I still have that joy of writing all of the information. But I think that gave us a really good stepping stone to be able to get people up and running very quickly. We sent out a consent form. We utilised our WhatsApp support group, so all of our members are on a WhatsApp group and they chat to each other. We send them resources of YouTube exercises, a bit like Gemma and Philly were saying, in terms of it's really a nice platform now that there's so many free resources and information and signposting. You can really educate and improve people's self-management. And the participants have raved about that in terms of how much extra resources they've got for a bit of effort on our part, but not a significant amount. Safety tips and recommendations. We sent out everyone who's going to be exercising a recommendation sheet. We went through their setup at home in terms of what equipment they could use to make them safe. We spent a lot of time thinking about adjusting our emergency policies and getting kind of some key questions in place about making them think as well. So it wasn't all going to be on us. It was going to be thinking about what is their normal emergency policy. If they were to fall when they weren't doing our exercise class and they were doing Joe Wicks or they were doing whatever else on YouTube they were trying, what would they normally do? And we kind of then went through that with them into our emergency policies. So we made ourselves safe as well as them being safe. And we spent quite a lot of time in the initial one-to-one assessment getting the setup as good as we can. And actually it's still not perfect, but lots of people are exercising when they wouldn't have. And we wanted to encourage people to feel confident and free to move. So in terms of our assessment, we've adapted it quite significantly from our hands-on assessment within the studio. But I think lots of it will probably end up keeping, and certainly it's nice that we're now got no geographical boundaries. We've got someone who's joined our sessions from Northern Ireland, having heard about it, their physio heard about it on another webinar where we presented. So that's like a really lovely story for us, the fact that the reach is increasing and we'll be able to help more people. We take a subjective history, we look at objective outcome measures, and if they've got a BP monitor and a heart rate monitor at home, we try and get that as we would have done in the studio, or we try and kind of get an appreciation of where they are from a cardiovascular point of view from their GP. With sensory work, we've adapted to think about more listening for descriptive words and observations in function. So what do they do in their functional tasks if they don't have their eyes, and how do they move objects from hand to hand, or how do they integrate with a weight or the TheraBand, and giving them a percentage of what kind of their sensation is like. Thinking about tone, obviously you can't be doing your modified Ashworth and kind of your kind of more objective measures unless you try and utilize the carer, but we were really focusing on, we didn't want to do that. We can get a lot of tone from our observations as therapists, and I think it makes you really observe people in a really positive way. We're looking for associated reactions, looking at the associated reaction rating scales. We're thinking about them using descriptive words, pulling out spasm frequencies, getting them to keep spasm kind of diaries and responses to more challenging exercises. And again, trying to make those kind of observations that they were a bit more tuned into their body and listening to that implicit information that comes out of movement analysis. We went away from kind of doing a formal power assessment really to more movement screening and looking at functional strength. So doing 30-second sit to stand and kind of more kind of functional based outcome measures. Coordination, we adapted like finger nose, so doing finger to a target. You can still do all kind of dysautokinesis and heel shin quite easily with a video camera. So that can give you a lot of good information. Balance, it's pretty easy to do outcome measures, but it does give you a little bit of heart rate yourself as a physio. So sometimes when you see someone closing their eyes and they're wobbling on the screen, you have to be brave and give them the education to think about how they're going to do that well. So are they in the corner of their room? Are they with a kitchen work surface? Have they got a strategy to know which way they might fall if they are going to lose their balance, and can they react to that quickly? And can you cue them into that really? Thinking about what Philly said in terms of you can do loads of things about attention and cognitive screening remotely, and it gives us some very good rich data. You can really see the people who struggle with dual tasking and trying to keep the instructions from us as therapists doing the class a bit more succinct. We certainly haven't been able to use music like we do in the studio, but again, that's allowed people to listen a bit more to their own bodies and to respond to what they're doing. So that's been a good learning point from our point of view. we haven't been able to be as strict as we would have done with orthotics and footwear. So people sometimes don't want to have their AFO on at home and they have less stability, and we've allowed them to accommodate to that and think about how we adapt the environment to help that kind of stability. Or we've encouraged them to try exercises for part of the class with their orthotic on and then removing it for other parts. So it is being a little bit more versatile and trying to respond to the thing that's in front of you. We've done a lot of outcome measures. So these are on the left are our outcome measures we used to do in the studio. And then from April, we moved on to doing kind of the EQ5D, 30-second sit to stand, like the kind of balance sequence there. And we have an upper limb group as well that we're just like starting at the moment. So we've been doing the ARMA, the motor activity log, motor assessment scale, and then taking photo screenshots and then using that for electronic goniometers. And that's a really useful bit of technology that, again, we wouldn't have done. We would have measured that with a standard goniometer, or you would have had a feel and estimated an eyeball range, whereas you've got some nice photo outcome measures that then the patients can like see as well. So the question is it as effective? And I suppose actually what we've seen is our assessments have been very good. What we've picked out from our movement screens and analysis has guided us as treatments and been able to adapt the exercises. We did this reassessment of someone yesterday who's a 78-year-old man with like left side of weakness, and his measures have significantly changed just in 12 weeks. His sit to stand, for example, went from 9 to 14, which is massive in terms of strength. He's got significantly more balance in terms of his right single leg stance, going from 10, like 0.65 seconds to 37. So that's a 26-second improvement in a very short amount of time. And that's from dosage and him practicing lots. And I think the confidence to exercise, I think that was really encouraging, because actually fear provoking of falling and doing remote exercise is high. And he went from a 7 to a 1. And all of our fears are reduced as well. So I think the data that we're getting through at the moment, and we've got a kind of a reassessment process going, is very similar. Yes, a few people haven't changed as significantly as him, but actually all of our participants have changed in their sit to stand. All of our participants have had some improvement in their balance, and most of them have had a really good satisfaction response to tele-rehab. We've used Microsoft Forms. I'm sure people have also utilized that, as well as Microsoft Teams, where you can have a really good integrated survey, and that's been a nice way to capture people's responses. I'm just going to whiz through this because I'm mindful of time, but I think from the positives of telehealth experience, as all the other speakers have said, I think we've had loads of just joyful moments in terms of rehabilitation. We've seen people really come together as a unit still. They've got lots out of still remaining in a group. They're making physical changes, but also they haven't felt socially isolated at a time where loads of them who live alone and neurologically impaired and were shielding could have been very impacted on what they were doing. Touch wood, I'm sure every time I say this, I think the next session we see someone does kind of something happen, but we haven't had any clinical incidents. There hasn't been any falls. I think that's because we've invested a bit of time in setting up people's environments and adapting the exercises to the person in front of them. And I think difficulties and challenges, they're all the same really. So thinking about the time it takes, you often need to do a bit of a double appointment to set up their IT, and then to think about gaining the physical assessment, the internet just dropping out, and having kind of progressing equipment and the costs of that. We can be really novel and utilize anything in their house, but sometimes people miss the specific equipment that we have in the studio. And as a charity, there's loads of free virtual exercises available. Yes, they don't have the support of qualified physios, but that's been a barrier for us as well in terms of growing as a service. And just to finish, I think one of the highlights is always to hear back from participants. And this always is, like, for me, the ultimate thing to know when the service has worked and changed. And the fact that these comments have just shown how much people have valued it, people have invested in it. I would not have survived lockdown without the legs classes. That just is amazing. I did not know I could run and jump. A big thank you. And we're pushing people to do things that they just didn't think was in their capacity. And this is fundamentally, shielding would have meant deconditioning, isolation and loneliness. But with the support of legs, I feel stronger, connected and supported. And that was the 3 big things we wanted to do when we started this kind of remote journey. We wanted to keep people feeling really connected and supported, but we wanted to make a physical change. We weren't doing this just to kind kind of keep them going. And that's kind of where we're at. Any questions or any more details? All my details are here on the slide, and I'd be happy to take any questions through the chat. Thank you very much.
Thank you, Sarah.